much more so I and my family, had a huge life-or-none wager riding on this never-ridden horse. But 6.5 hours later, the race was won. Gabby can always read Mac's face, and when he came to see her, she knew immediately that he had cajoled this snorting, pawing horse to the winner's circle. He had Kentucky Derby all over his smile. Fortunately, the fistula was alone, and Mac was able to nooger it free. If ever there were a time and a place to exercise masterful noogering, these were them. For any of you as yet uninitiated in the art, the definition of noogering is to nooger. The very odd gastric stoma stayed behind with the trachea, while the conduit side of the defect acquiesced willingly to simple suture repair. As further insurance, Mac chopped out my 6th rib, pedicled the adjacent intercostal muscles, and partially wrapped them around my conduit as a buffer between it and the trachea. He told me, "I never want to be back here." Any gastric mucosa foolhardy enough to mount an expedition to the trachea would now be repelled by an impregnable moat of muscle. Every time I take a deep breath or cough, I imagine, happily, my mostly atonic conduit getting an encouraging squeeze. Fascinatingly, I knew, even under anesthesia, the instant the stent was removed. It was as though a switch had been flipped off, and my awful cough stopped instantly. My recovery was quick and uneventful, if painful and breath-sapping. This is the warranty that comes with a redo thoracotomy and a complicated operation. The snail resumed his feed and walk routine. And oh yes, there was one small detour. 10 days after I came home, I awoke with a bone-shaking chill and a fever that soared to 104. Gabby rushed me to the hospital. Scary possibilities ran rampant, but my chest x-ray revealed only a right-sided pneumonia. Was this a residuum or a harbinger of things to come? Fortunately, it appears to have been the former rather than the latter. Regardless, the storm subsided rapidly with antibiotics. My chest x-ray steadily looks more normal, and my paralyzed right diaphragm is slowly regaining some function. Yet another 7 weeks, and Mac declared me ready for the final operation. This one to restore my gastrointestinal continuity, that I might eat again. Nary a drop nor a morsel had breached my cricopharyngeus in over 4 months. The smell of food was maddening. Frankly, I was quite fed up with tube feeds, and surely the pump was close to burning out its incessantly creaky bearings. Both Mac and I were far too experienced in the vagaries of surgery to view this operation as a chip shot. Mac's strategy of stage repair had proved spot on, and he was not about to jeopardize the final product. A leak or a fistula would be ironically desolating. Given the previous struggle in the abdomen, Mac elected to split me with a left thoraco-abdominal incision, which would afford him maximal exposure and maneuverability. Surgeons love this incision, patients hate it, he quipped. He reminded me that this is the most morbid of all surgical incisions. He was correct. His plan was to bring up a Roux-Y limb, snake it through the hiatus, and perform the hookup in the chest in clean territory, away from the battered G-tube site. This would put paid to any further bilious sojourns north of the diaphragm. It was a long and tedious operation, but once again Mac's judgment proved sound, and the operation was technically successful. But holy samurai saber slash Batman. This is one damn long and painful incision. I could hear the fibroblasts fuming in unison. Mac had outlined with his finger a short intercostal swoop with a quick jog across the costal margin to the abdomen. I suppose it was best that he didn't draw the whole thing. It spirals nearly hemicircumferentially from somewhere on my far posterior chest, across the margin, and tails all the way to the midline of my abdomen. I worried that one cough or sneeze, and I might pop open like a whack on a can of Pillsbury refrigerated rolls. The doughboy would not find that finger dimpling funny. But no mind, pain is pain. Incisions heal from side to side, not from end to end. Yada, yada, yada. For once, my epidural actually worked. But the trade-off was that nursing policy demanded sensory level testing with an ice pack, 7 levels, right and left, front and back, every 2 hours. This inflexible routine was enough to make me cold-hearted. On POD4, the goddamn NG tube became terminally clogged, despite my earnest and repeated attempts to flush it clean. Not that I wasn't tempted to sabotage the vile snake. Out it came, and an 8-day stint was mercifully halved. Of all the tortures we inflict on our patients, this ranks at the top of my list. In short, Mac did what he had to do, and now I have a real scar to show off. Besides, only a few more days in room 722, my enshrined locus and comma at the Beth Israel, and I would be out of here. Visions of sugar plums, actually it was mashed potatoes and gravy, danced on my tongue. Well, it ain't over till it's over, as Yogi Berra was fond of reminding us. By this time, my often again punctured arms were bloodless turnips. My right arm looked like Popeye on steroids after an extravasation of amiodarone. There seemed no choice but a PICC line, which was placed uneventfully in my bruised and boggy left antecubitus. 2 days later, I began to experience paroxysmal dyspnea, heretofore merely a clinical term to me. But permit me to elaborate on its true meaning. It was the most terrifying sensation of my life. A feeling of sheer panic and impending death. I could not suck in enough air. The painful mechanical restriction of my chest wall from the surgery only compounded the feeling. I could read the O2 sat monitor, 98, but my panic was in no way relieved by mere numbers. When Usain Bolt flashed across the finish line in the 100 meters in Beijing, he was gasping slightly, but he was not dyspneic. He was euphoric. No mystery, then, that induced dyspnea is the most effective means of torture ever devised. A CT scan now revealed multiple bilateral pulmonary emboli, a textbook cause of my symptoms. The source of these emboli was unclear, as my lower extremity and pelvic ultrasound was normal. The heparin was duly started, and my dyspnea improved almost immediately. Heparin is not only an anticoagulant, but a powerful anti-inflammatory, which counteracts some of the chemical mediators released from the clots. 2 days later, I felt much better, turned the corner better. It was early afternoon. I was packed and pillowed into the Cadillac chair. Gabby was sitting next to me. Without pain or warning, I felt something warm burbling into the back of my throat. I spit out some blood, then some more, then a lot more, and bright red. Gabby was terrified. I, for some reason, was quite calm, perhaps a wounded soldier's battle shock. The SWAT team was all over me, and in a flash I was trundled up to the SICU, agreeing by nod to an awake intubation. An upper extremity ultrasound now revealed spaghetti-like tendrils of clot attached and unattached to the end of the PICC line, waving like reeds in a river. Stop the heparin, call the vascular surgeon, call the gastroenterologist, and wheel me down to the interventional suite. Gastroscopy revealed my conduit full of clots, but no active bleeding and no source identified. 8 units of blood later, my hematocrit finally grasped the top rung of the ladder at the 30 mark. Unlike one's age, I found it particularly reassuring to hit 30. 29 just didn't seem like enough in the tank. Dr. P threaded a nitinol filter into my superior vena cava and deftly deployed it in the upside-down position. Follow-up ultrasound showed no residual clot, and given a clear and eliminated external source, I have been spared